with a focus on crisis context. I'm Priyanka, and I'm the Evidence Hub Manager at the Global Schools Forum. For those of you who are new to Global Schools Forum, Tejaswini, can we go to the next slide? GSF is a collaborative community innovation accelerator and a partnership builder for non-state organizations working to improve education at scale for children in low and middle income countries. Currently, we're a community of 165 organizations working across 63 countries, running and supporting over 1.3 million schools and centers and providing education to more than 126 million children. Next slide, please. One of the projects at GSF is on building an evidence hub for early childhood education and development in emergencies. The hub codifies promising local solutions, models, and approaches to improve education and well-being outcomes of children and families in crisis contexts. If you'd like to learn more, you can scan the QR code on the screen and access our resources developed so far there. But a web link is also available, which I'll shortly post on the chat. As part of our work, we have been running various learning series, and the PSS learning series is sort of one such topic that we are exploring as part of the group. Let me, just very quickly share the link to the Evidence Hub with everyone. So like I said, this learning series is a 4-part virtual learning series. These are sort of weekly in nature, and they will happen every Wednesday from today till the 2nd of April. We have contributors and collaborators who have supported us in sort of bringing this learning series to you. So we'd like to acknowledge and thank the Moving Mind Alliance, INEE, AMNA, Semilla Riapego, and representatives from UNICEF and WHO for their support in putting this learning series together. The details of the sessions are on the left side of the screen. As you'll see, we're starting with a big picture understanding of the what and the why of PSS. However, you'll see in the upcoming sessions, there's a shift to the how. So the sessions will focus more on strategies, models, approaches that help integrate PSS programming into your interventions, and we'll co-create much of this in a very workshop-oriented format. Our one request, therefore, for all of you who are joining today would be to attend all the learning sessions to maximize sort of your learning on sort of this topic. Our next slide, please. So that brings us to objectives for today. Like I said, this session kind of helps us zoom out a little bit on the what and the why. So we look at the evidence and what it says about PSS programming for caregivers with young children living in crisis context. We will also unpack what the term really means and what are some key components of it. And as a group, really align on that understanding that will guide us through the rest of the learning sessions. And 3, we will also engage in a little bit of self-reflection, both independently and with our peers, and think about the needs of caregivers within our own programs and what support areas can be potential entry points in the long term. We'll start off this panel discussion, and then we'll get into a small group exercise and then end with a large group Q&A. So lots of exciting things are planned over the next 1.5 hours. Next slide. Just a couple of points on housekeeping. One, the session is being recorded, so we will share the link with you and the key takeaways and all the resources that we bring and showed to you today right after the session. There's also time for Q&A, but please feel free to submit your questions via chat or use the raise hand feature on Zoom throughout the session to engage in case you have any burning questions. And third, there'll be a poll towards the end of the session to gather your feedback. We request you to take it, as it really helps us think through what worked and what didn't, and therefore what adaptations we need to make in the future to make this as relevant and useful for you as possible. Next slide. On that note, I am going to pass it on to Nour, who is a senior manager at the Moving Minds Alliance. The Moving Mind Alliance is a funder collaborative and a network convened to scale up coverage, quality, and financing support for young children and families affected by crisis and displacement. Nour is a refugee advocacy and inclusion expert with about 11 years of experience in this area, and she'll be able to bring lots of interesting insights for us, and will be facilitating the panel discussion for us. So over to you, Nour.
Thank you so much, Priyanka, and thank you for inviting MMA to collaborate with GSF on this amazing series. Good morning, afternoon, everyone, and welcome. As Priyanka said, I'm Nour Jarrouj, and I'm here to help moderate this session. And we're here today to discuss a topic of critical importance: the mental health and well-being of caregivers with young children in situations of crisis and displacement. Caregivers in these settings face immense challenges. They are often dealing with trauma, loss, and constant stress of uncertainty and instability. This can have a profound impact on their ability to provide nurturing care for their young children and affects their children's development as well. We all know that the early years are a critical period for child's development, and responsive caregiving is a key contributor to their healthy development. But when caregivers are struggling with their own mental health, it can be really difficult for them to provide this type of care. That's why MHPSS services are so essential. I wanted to share evidence, but then I'm not going to, because our expert panelists will do that job much better than I can. Instead, I spoke to my sister, and I want to share her true story, a forcibly displaced mother who lived in the Syrian war, facing death, being displaced with her family and kids. I told her I was moderating this session, and I asked her a few questions. What does she think about MHPSS when she was a 26-year-old mother with 2 kids in Syria? And this is what she shared. Where do I even begin? During the war, my life was a constant struggle for survival. Keeping my children alive was my only focus. It's hard to describe the trauma of daily death and fear for my family, all while trying to work and provide for my kids. I even had to take my 2-year-old sometimes to work with me amidst the bombing and the shootings. I had to ignore my needs completely. I didn't even have time to process what was happening. After being displaced multiple times and witnessing so much death and destruction, my mental health deteriorated drastically. Losing our jobs added to the trauma, stripping us of our purpose. I felt isolated, deeply depressed, and disconnected from reality. I was ashamed and afraid of the stigma surrounding mental health in Syria, but I suffered from constant flashbacks. And then when I finally confided in my mother and saw a doctor, I was diagnosed with depression and prescribed medication that didn't help much. I felt hopeless, wishing I wouldn't wake up. But then I'd see my children and know I had to keep going for them. The lack of support affected both my well-being and my child's development. To raise good children, you need to be well yourself. I was constantly angry and overwhelmed, unable to provide the stability and nurturing my son needed. We were displaced 6 times before he was even 9. Never having a stable home or a normal childhood. My daughter developed severe anxiety, and sometimes I blamed myself, perhaps because of the stress I endured while pregnant. I lacked awareness about mental health, and wish someone had simply told me it's okay not to be okay and what I was going through was normal. There was no mental health first aid available then. I found purpose in supporting other displaced families. But access to psychologists and trauma specialists was non-existent. The war also strained my relationship with my husband, impacting how we parent our kids and deal with them. After a while, I was working to support other displaced families like ours in Homs and the surrounding villages, and through my work with the local organizations, I received mental health training on how to support other people with trauma, which helped me understand my own experiences. However, I wish there had been more coordination between mental health and other services, because how can we build resilience without having access to basic needs? How could I support a woman through MHPSS service when her kid needed medication and she couldn't access it? Or another woman was living in a tent in an IDP camp. We needed holistic support, including mental health, shelter, nutrition, child-friendly spaces, and healthcare. We needed support that is tailored to our community and led by people who understand the culture, who understand the stigma around mental health, and who could influence and mobilize the community to take part in MHPSS services. Now it is needed more than ever for Syrians everywhere. I am now a displaced mother in Europe. I know that my story is not unique. Millions of other caregivers are facing similar challenges, but it's crucial that caregivers are prioritized in emergencies. Like in an airplane, you must put your own mask first. If we don't support caregivers, we risk losing entire generations. I now advocate for other displaced women in war, hoping they won't endure what I had to endure. I'm still scarred and anxious, but I'm a fighter, and I keep fighting every day to give my children the best possible future, compensating for what they've lost. So if you guys need proof why MHPSS for caregivers is important, speak to mothers who have survived war. Speak to mothers and parents who have survived displacement. And to learn more about scientific evidence and tools and examples, we will now need to hear from our amazing MHPSS expert panelists. And I'm honored to introduce you to Dr. Ashley Nemiro, Dr. Andres Moya, Patricia Landines Gonzalez, Eduardo Garcia Roland. And we will start with Dr. Ashley. Dr. Ashley is a licensed clinician with over 17 years of experience in program development, implementation, research, teaching, and direct clinical services. She specializes in children, youth, and families. She's a global mental health professional with an emphasis on integrating mental health care into health, education, and protection services. She also developed supervision systems, working with others on policy change and training, and assisting staff in using psychological interventions. Ashley presently works at WHO, supporting EASE, global capacity strengthening activities, and disaster risk reduction and mental health and psychosocial support efforts in humanitarian emergencies. Dr. Andres Moya is an associate professor of economics at the Universidad de los Andes in Bogota, Colombia. He has a PhD in development economics from UC Davis. He's a director of Semillas de Apego and commissioner for the 2024-25 Lancet Commission on Health, Conflict, and Forced Displacement. His research focuses on understanding the consequences of conflict and forced displacement and how they thrust people into poverty through economic, psychological, and behavioral channels. Building upon this evidence, he designs and evaluates interventions to mitigate these consequences and foster movements out of poverty. The prime example of his work is Semillas de Apego, a community-based psychosocial program for caregivers and young children in communities affected by conflict and forced displacement. Patricia Landines Gonzalez is a psychologist and art therapist with over 18 years of experience in MHPSS across Asia, Africa, and the Americas. She supports UNICEF education team in HQ in integrating MHPSS within the education sector. She joined UNICEF in 2010, and Patricia holds master's degree in art therapy from NYU and public policy and humanitarian action from Paris 12, along with a BA in psychology from Pontificia Universidad Javeriana. Eduardo Garcia Roland. Eduardo is a humanitarian worker with more than 25 years of experience in child protection, management, emergencies, education, and early childhood development. He holds a law degree and master's in international humanitarian aid from Spain and Germany. He started working in Latin America and Peru in 1995, and since then, Eduardo has been involved in loads of emergencies and civil wars and natural disasters in Burundi, Rwanda, DRC, Sierra Leone, Colombia, Mexico, Haiti, Sri Lanka, Jordan, and I have etc. So it's a lot more. He has worked in civil society organizations as well as intergovernmental agencies. Previously, Eduardo worked in the Middle East as UNICEF ECD and ECE specialist since 2017, based in Amman. Nowadays, he's an early childhood development specialist focusing on humanitarian setting with the Child Nutrition and Development team globally. So just wanted to let you know, you are in good hands. You have all the amazing experts here with you. And please, I would like to ask you to listen attentively. So a question to ask our panelists. Could you share briefly about your MHPSS work focused on caregivers with the youngest children in crisis and displacement? You have around 2 minutes each. So over to you. Let's start with Eduardo.
So I don't know what to say. Hi everyone. I am so overwhelmed by the bios of my panelists, and so thrilled by being here in this event, and very thankful to the forum to organize it and to organize this series. I don't, in terms of the whys and why we should do this, I don't think I have anything to say because Nour, and I'm so happy to see you again, the testimony of your sister says everything, right? And I don't think we need to find any other explanation, but to listen to our fellow humans who are being suffering from this situation. And you know, if you have a child, if you are a father or a mother, you know how paramount is in your life to support them. And if you have any knowledge of what it is, the early development, you know how important it is to provide that nurturing caregiving. And obviously I'm thinking about my daughter when I say that, but I really think you said it all, Nour, or your sister said it all with real experience on why this is necessary. So without further ado, it's not that much on why, it's like, let's jump on the how, right? And how to do it best, and being delighted and enjoy the company of my co-panelists because we actually have the evidence that there are things that work, right? So that's what we have to build upon. That's why we are here, and that's why we are so delighted to have all these 40 people around the world following us to see how we are going to do so.
Yeah, thank you so much, Eduardo. I would turn to the other panelists if you would like to share any other briefly about your MHPSS work that is focused on caregivers and young children in crisis. You have also around 2 minutes.
I can jump in, Nour. So I just wanted to say, Nour, thank you so much for sharing your sister's story. It was incredibly moving and real. And I believe that we need a lot more of that in the work that we do versus just sharing statistics or kind of broad overview of why this work is needed. But people's individual stories is just so powerful and impactful because it reminds us of the humanness that's involved in all the work that we do. So the work that I've done in the MHPSS space has really been around supporting children, families, and caregivers. And a lot of the work that I focus on is writing and training non-specialists on the delivery of psychological interventions, and also training teachers and providers on how to support children's mental health and well-being and caregivers' mental health and well-being. So one thing that I believe in very strongly is that we need to have a whole family approach. So it's not just about addressing caregiver mental health and well-being, but it's really looking at the whole family, how the environment that they're living in and their situation is affecting their well-being. And I'll speak a little bit more about the psychological interventions, but the one that I particularly work on, it's actually for younger adolescents, but there is a very strong caregiver component because it speaks to the bi-directional relationship between a caregiver's mental health and well-being and the child's mental health and well-being. So really excited to be here today and talk about a topic that is very near and dear to my heart as a mother, and then of course something that a topic that I work in. So thank you so much.
Thank you, Ashley. Andreas?
Sure. Thank you, Nour, and appreciate the invitation. And again, I'm going to echo Eduardo and Ashley in mentioning that I was very moved, and I want to thank you for sharing and your sister. I want to thank your sister for coming out and speaking about this in this human terms, right? It's sadly, there's a lot of suffering right now in the world, and we need more of this because it's the humanity, right? It's how we deal with these adversities. And I think you mentioned this. She mentioned this. It's normal to go through all these struggles. What would be abnormal would be that we could navigate these challenges and not be affected. And so I'm a development economist. I've been working on forced displacement in Colombia. Colombia is a particular setting because we have experienced decades of conflict, low intensity conflict, but ongoing conflict. Right now, there's 9 million people who have been affected by and are legally recognized as victims. In addition, in the last 8 years, we've been the largest host of Venezuelan refugees, almost 3 million Venezuelan refugees. So if you add them for the stats, we have 12 million people in Colombia, around 20% of the population who have been forced to be displaced. And despite legal frameworks to protect victims, to protect conflict-affected populations, also to support Venezuelan refugees, there's a gap in understanding the intersection between mental health and early childhood development, right? And so often we, and I think echoing what Ashley was mentioning, we neglect or we miss this bidirectional relationship. We miss out that we're asking too much of caregivers when we ask them to be able to navigate these adversities and at the same time be able to provide the nurturing care that children so much need, right? And so I think what we do in Semilla de Apego is we take a step back. So we designed this community-based psychosocial program. It's led by members of the communities. And what we do is different to maybe other early childhood development interventions. We take a step back and we start working with the caregivers and supporting their mental health. Their mental health as an outcome by itself, but also as a pathway through which we can promote the healthy child-parent attachments that we know can buffer and can protect children in the midst of these adversities. So that's the work that we do here. And again, very honored and grateful for this invitation.
Yeah, thank you so much, Andres. Patricia?
Thank you very much. And thank you for the opportunity to join this discussion and also honor to share the space with the participants and excellent panelists. As you mentioned before, I work with UNICEF headquarters, specifically with the education team, working on advocacy policy level, also developing some relevant guidance and documents for the field around the integration of mental health and psychosocial support services and programs within schools and early learning environments. And I think it's important over the past 4 years, we have been insisting at the global and really regional level the importance of integrating MHPSS within schools, including learning environments. And I agree with Eduardo that we need to focus not only on the why, but in how and generate new evidence about what is working well in schools in different settings, especially in low-income countries and also in crisis context. What I have been working is on advocating for key programmatic priorities. I will just mention very briefly, so just for you to know, because this is also, I think, relevant for the youngest children and is on enhancing the mental health literacy of the school community, so students, educators, and caregivers from early childhood, expanding access to mental health services within schools or through schools, supporting teacher well-being as a critical pillar of education-based mental health and psychosocial support, building the capacity of teachers and support their capacity, and of course, strengthening this important collaboration between schools, the caregivers, and teachers to promote a safe and nurturing environment for schools. I'm happy to discuss more later on specific interventions for this target group in emergencies. Over back to you.
Thank you, Patricia. And thank you all for sharing this amazing array of expertise and programs you're working on. So coming back to you, Ashley, could you help us better understand the term MHPSS and explain what does it actually involve in practical terms? And what do you think are the key components that the practitioners should focus on when working with caregivers of young children?
Yes, thank you so much, Nour, for that question. I'm going to briefly share my slides. Can everyone see? Fantastic.
Yes.
Okay. I'm just going to put it into presentation mode really quick. Okay, so the term mental health and psychosocial support is a composite term that really looks at prevention, promotion of mental health and well-being, and then care for people who are living with mental disorders. We use this composite term as a way to ensure that programming, activities, services go across a continuum. So it's not just that you have specialized mental health services, but you actually have a whole host of services that really support people's mental health and well-being at every stage of their life and based on their unique experiences. So I show the famous mental health and psychosocial support pyramid of interventions because I think it really does help describe what we're talking about when we refer to mental health and psychosocial support, or MHPSS, as you'll hear me say. So this first level is really basic psychosocial support. And as you see here, the first layer is really universal intervention. So if we're looking at caregiver and young children, this is basic information that we're providing to young mothers, whether it be through prenatal or perinatal visits, for example. And focused psychosocial support is really around prevention of further psychological distress and mental health conditions. And then as you move up, you have psychological support. And this is really on the psychological interventions that I'll speak more about. And then as you go up, you have more specialized mental health care. As you go up this pyramid, there's an increased need for formal training, supervision, skills, and competencies. And of course, surrounding all of this is the protective environment. And as Nour so beautifully articulated with her sister, it's not just an individual's mental health and well-being, it's everything that is surrounding them that affects their mental health and well-being. And so we can't really address mental health and psychosocial support without thinking of the social determinants of health and the environment and the context in which individuals are living in. And if we're going to be really practical, it's important that we think about, okay, so what does this mean for caregivers and young children in terms of services that they can access? So, for example, there's a psychological, oh, sorry, my computer froze. So at WHO, we have a psychological intervention that's called Thinking Healthies. And this intervention is for mothers with perinatal depression. So this intervention is really about supporting caregivers before their child is even born. So in the prenatal period, and then continuing to support the mother during the postnatal period. This is through home visits. It can also be delivered in a group-based setting. And it really looks at that third layer of the pyramid. So focused psychological support. And if you look at kind of the lower layers of the pyramid, it's also about how do we provide information to caregivers, to mothers during their prenatal visits or their postnatal visits. How are we catching mothers who may be more vulnerable to experiencing distress? How do we catch mothers after they've given birth to their child, as their child's getting older, who may be really struggling based on everything that we've already talked about today, the conditions in which they're living in, really, how do we catch those mothers and caregivers who are living just in a state of survival? And so when we talk about mental health and psychosocial support, it's not only the services that we provide, but it's also all of those prevention aspects that are so important. And unfortunately, I'll talk about this a little later when we talk about evidence, but we have the evidence, we have the evidence-based interventions, the programs, but they're just not being brought to scale by any means. And I would say one of the most important things is that we're not meeting caregivers where they're at as it relates to mental health and psychosocial support, because we know caregivers go to visits at the health clinic. We know that some children are engaged in early childhood development activities, but are we then speaking about mental health and well-being? Are we taking any preventative measures or mental health promotion measures that really support their well-being, not only as individuals, but as families and as communities? And so, interestingly enough, as I said, we have a ton of examples of really how to operationalize the mental health and psychosocial support pyramid of interventions for caregivers and young children. But for one reason or another, there's not money invested in this. I'll continue on that when you ask about research. But I think we're also just prioritizing oftentimes physical health over mental health and well-being, even though we know those two are so distinctly linked together. But due to so many factors such as stigma, et cetera, it's often not addressed.
Yeah, agree with you totally. Thank you, Ashley. Andres, could you please share some of the key findings from your research on the Semillas de Apego program, particularly regarding the impact of supporting caregivers' emotional well-being in crisis, and how this connects to the child development section?
Sure, no, thank you so much. So again, I'm part of Semillas de Apego. Semillas de Apego translates as a seed for attachment. And the idea is that we want to restore the natural capacity and the biological capacities that caregivers have to connect with their young children in warm, nurturing ways, and in these ways that conflict and all these adversities are hindering. Oh, whoops, sorry. So again, we're based at psychosocial community-based program. We again, just to highlight, we promote mental health and we try to restore caregiver mental health as an objective by itself, an important objective by itself. But it's also the way in which we restore these natural capacities to provide the nurturing relationships. So we work with caregivers in context of conflict, displacement, and other adversities. And the way that the program is structured is a group model. It's 15 weeks, so it's a 15-session program that lasts. There's one session per week, and the groups are based with 15 to 20 caregivers on average. This is important because the group setting is going to help you tackle stigma on mental health, recognize that what these caregivers are going through and struggling, and that many times they're struggling by themselves in silence and isolation. The group setting allows them to learn from others, to recognize that these are normal reactions to very abnormal and traumatic circumstances. And it's also led by community facilitators, so these are paraprofessionals. And the community-based model is important because, one, it allows us to deliver a program in a feasible way. There's a lack of mental health services in general in Colombia, despite of decades of conflict, but more so in the communities and municipalities more affected by conflict. So I think, as Ashley was mentioning, there's just like tiny resources invested in mental health support and tiny resources invested for early child development. So the community facilitators allow us to deliver this program. This requires a level of supervision, and more than supervision, what we implement is what we call reflective supervision, because it's mostly focused on the well-being of the facilitators who lead the program. The facilitators are members of the community. They're all mothers. Many of them have also been displaced, affected by violence, targeted, and so on. And so the way in which they lead the program is from their own experience. And this is also important because then it allows caregivers to connect with the shared experiences of the facilitators. And this creates a space also for learning, for addressing mental health stigma, for recognizing that healing and change is possible, right? So around the 15 weeks, what we do is in the first part, we focus on creating awareness on mental health and the way in which conflict and these other adversities are affecting the well-being of the caregiver. Also providing tools for emotional regulation through, for instance, some breathing and mindfulness practices, as the slide is showing. Then the program shifts the focus into what is happening with children. More often than not, when caregivers reach this stage of the program, they tell us, well, but my child was too young to actually know what was happening, that we were being displaced, that we lost a family member, that we're struggling. And then they start connecting that this is just entirely the opposite, that they're also suffering, that they're also experiencing the adversities, and they, just as the caregiver. So by promoting this emotional awareness, the caregivers are also recognizing that children have their own emotional and complex emotions by themselves. And so this allows them to connect emotion. This allows them to start connecting in better emotional ways with their children. And by the end, what we try to focus is on restoring and creating parenting teams as a way in which we can also lead to sustainability in the impacts. We've tested this program for 12 years now in different stages, different evaluations, thinking about processes, thinking about how and whether we can promote and strengthen this community-based intervention. We've also conducted impact evaluations in very difficult contexts with ongoing conflict. And what we've shown in this evidence is that the program is feasible, it's highly accepted by the participants and communities, and that it has high impacts in terms of the mental health of the caregivers. For instance, we see reductions of 38% in phobic anxiety, which is closely related to trauma and to evoking memories and of conflict and displacement. We also see that it lowers the likelihood of at-risk symptoms of parenting stress, harsh parenting, harsh disciplines, and so on. And we also see important reductions of 32% in terms of the social-emotional problems of young children, mental health symptoms, and development. And just to wrap up, we have some evidence that the program is cost-effective. The rate of return of the program is around 12. For every dollar that we invest in the program, the society gets back $12. So it makes sense. It's feasible, but it also makes sense. It has impact on the communities. It has impact on the caregivers. It has impacts on the children. And so what I'm trying to highlight is that we need to pay more attention to these to the intersection between caregiver mental health and early child development, and that it's possible, it's feasible, and it's effective to do this, even in these very adverse settings. So let me stop there.
Thank you so much, Andres. And one thing you mentioned that is cross the continents is about like the lack of understanding that what young children see when they're really, really young doesn't affect them or stay with them just because, oh, they're too young to understand. And I've seen that, I've witnessed that firsthand with my nephew and niece, like years after they're still having flashbacks of things that happened when they were like 2 years old, 3 years old. So yeah, it's definitely, there's a lot of evidence around that. Eduardo, Patricia, could you please share a bit about Hope for Children and what does that entail? And what are the key learnings from testing and adapting in countries in crisis? How do you think it differs from caring for the caregiver module that UNICEF has?
Sure. Maybe what we can do is we can show you first the care for caregiving model, Patricia, and we have a case study also, and then we'll let you how we have adapted more on specific emergencies. That was a real challenge in the most problematic settings, I would say. Patricia, do you want to go first?
Patricia?
I was trying to find the button. I'm so sorry. I was
No
muted.
worries. No worries. No worries.
So just I will give you like a broad picture maybe about MHPSS, as I mentioned before, in education, and how it is also in crisis and in emergencies. I don't know if you are aware, but recently an essential tool was endorsed by the Interagency Standing Committee, the minimum service package for mental health and psychosocial support, with really highlighting core activities that can be implemented by different sectors, not only in the education, to support the mental health and psychosocial well-being of populations affected by emergencies. And in the screen now, I hope you can see, I just highlighted, because I work in education, those activities that are recommended for the education sector to integrate into emergency and education and emergencies response. And highlighted, you see that one of the core activities that implementing partners, governments, UN agencies can be implementing in education in emergency response is integrating activities to support the mental health and psychosocial well-being of children and caregiver in early childhood education programming. And this is just, like very briefly presentation. I will share in the chat the links to the documents I have been shared. And in a few minutes, I'm just wanted really to highlight that this is one of the core activities that we can be implementing in education. And one tool that has been, as you mentioned before, that has been developed by UNICEF is Caring for the Caregiver. That was developed, I think, in 2018. It was initially developed in Sierra Leone. And then it was, let me check and then it was expanded to additional countries, including Brazil, Bhutan, Zambia, Serbia, Malawi, Rwanda, and others. And it's basically a package to build the capacity of frontline workers to provide adequate counseling and parenting support services to improve caregivers' emotional well-being and their the capacity to have this nurture relationship with the children. And in Bhutan, it was specifically, just to give you an example, not necessarily on crisis, but in Bhutan, it was a collaboration between UNICEF, the Ministry of Education, and the Ministry of Health, how they integrating this package into the early education and parenting programs officially, and then reaching families with this package in home visits. And this is just one example of how it can be implemented in emergencies, but it can also be implemented as part of this type of system strengthening programming and supporting governments and partners to include embed this type of evidence-based programs in their current programming. So this is just one example very quickly, and I pass over now to Eduardo to talk about the other. And just to mention that I am talking about integration and education, but for us in UNICEF is a component on issue that is across sector. Over, back to you, Eduardo.
Thank you very much, Patricia. So I wanted to then share also a few slides here. Yeah, I hope, just let me know if that works okay. And so I wanted to explain one little thing. So Caring for Caregivers is a program that has started many years ago and has, as you have heard, been implemented in several countries. And it's a very in-depth counseling, one-to-one support. I think in the Ashley showed that a pyramid on mental health and psychosocial support. It will be more on the middle side of that psychosocial support. It was developed with also experts in mental health, and there has been also some studies with the university in South Africa. I am very jealous of Carlos whenever I hear about Semillas de Apego, which is a program that I have known for many years, because Semillas de Apego has such a long experience, 12 years of experience with several impact evaluations and showing so great impact in reducing anxiety, etc. So we have been confronted in the last years of emergencies and the onset of emergencies, in which some of these programs that has been mentioned here, including, for example, caring for the caregiver, were not quite good options for emergency responses, right? And so what we decided is to create one, we call it Hope for Our Children, that is specifically for emergencies. And it's a very short training for frontline workers. We have two packages of training, one that is focused on the caregiver well-being and mental health, and another one focusing on playful parenting. So what the interesting part of this program that we have developed is that we are using nutrition platforms. So child nutrition and development is a platform that is quite important in emergencies, because emergencies are very much, or many emergencies are very much defined by high levels of malnutrition. And so we had in UNICEF, we were prioritizing 15 countries that have the highest levels of wasting, which is the worst forms of malnutrition. And we wanted to use these platforms in emergencies and acute emergencies to provide mental health and support to the caregivers as our main allies in working in nutrition to provide nutrition outcomes and developmental outcomes. And we cannot do that if we don't work hand in hand with the parents and the mental health, and we address the mental health and the well-being of the parents. One of our main points on our theory of change for the nutrition interventions in emergencies, and more particularly for wasting programs, is that when children are well cared for, they are stimulated. When we look at the stimulation and the attachment of children with their caregivers, Carlos has talked quite a lot about that. Semillas de apego means attachment. That is going to improve, not only reduce the time for recovering for malnutrition, but also reduce the cases of relapses in malnutrition. And that is a key element for nutrition as one of the 5 elements of the nurturing care framework. Up to 75% of nutrients that a child takes in the first 1,000 days of life is going to nourish the brain, and is going to be essential for the development of a human being for all the rest of our lives. So the nutrition platform, as it is, other platforms, the health platform, and of course the education platforms are going to be essential to reach out to these caregivers where they are. Ashley mentioned that we need to reach out the parents where they are, and the caregivers where they are, the mothers and the fathers. Both of them need to have attention in mental health. Remember that not only mothers suffer from postpartum depression, also fathers suffer from postpartum depression, and that is going to be increased even more in emergencies. So Hope for Our Children is these short trainings for frontline workers. I was also a little bit jealous of Carlos when he mentioned that they are working with very specialized professionals. Oftentimes in emergencies, we are not able to work with mental health professionals. So we have to train on early childhood development and on mental health and some of the tips to improve mental health of caregivers with whoever frontline workers we have. So Hope for Our Children has been tested in Madagascar, and it's quite an interesting program. We have used it in the pediatric wards in hospitals, which I visited and I found terribly also depressing and not very conducive for development. So we use those, whatever we have, right? those pediatric wards where children are severely malnourished, to engage the frontline workers and through them, the parents, the caregivers, and the children to do stimulation, play, to improve parenting. But also we have been able through the Madagascar model to engage also civil society partners and to do so at the front in the communities. So we do both in the inpatient treatment for children, but also in the communities for prevention and follow-up with children to improve that attachment of children with their caregivers, to do the follow-up, to do prevention for malnutrition, and to facilitate that better mental health of caregivers and the attachment with the children. For the mental health of the caregivers, we have used all evidence-based tools that existed before. A lot of the things that we have done, and I was loving that picture from Semillas de Apego of breathing and mindfulness. We are looking at very practical ways for parents to better ground themselves, breathing exercises, being present, grounding exercises. Part of the actions that have been tested on emergency mental health for emergencies that have produced very good results. We have worked in rehabilitation centers. We have created guidelines for stimulation and psychological support for distressed caregivers and children. And we are partnering with to reach out to those parents and to those children. For example, through the Pediatric Society in Madagascar, in the testing in Madagascar, strengthening the health workers in psychosocial care and managing malnutrition. And that will be health workers and also volunteers, all the ones that could help us to reach out those children through better prepared caregivers that will be able to provide that difficult nurturing and that difficult caregiving, particularly in tough emergency situations. I think with that, I leave it to you, Nour. Thank you.
Thank you so much, Eduardo and Patricia, for showing us practical examples in both acute emergencies and protracted crisis. And just finally, a question to all of you as our expert panelists. What do you see the biggest gaps are in research on caregiver support programs in crisis? How do you think we can bridge the gap between the evidence generation and the practical implementation, especially in supporting caregivers of young children? We have 5 minutes left, I think, maybe 4 minutes left. So in 1 minute, if you can share a bit your expertise in that, please. I know, Ashley, you wanted to say something around this, so we can start with you.
Yeah, absolutely. And that's a really important question. I think I want to start by saying that we know we have a ton of data that suggests that poor caregiver mental health and well-being is associated with adverse child outcomes. We know that it's been said on this call. And even though these statistics and warnings are well known, it seems that caregiver mental health and well-being is hardly prioritized or seen as important. So we have programs that have been mentioned here on this call. There's other programs that are supporting caregiver and early child well-being, but it continues to remain a low priority. If you look at spending in crisis and conflict settings on caregiver mental health and well-being and early childhood mental health well-being, it's next to nothing. And I think most importantly is we spend so many resources, still not enough, but on making sure that the child arrives safely into the world. And it seems like once the child arrives safely into the world, then all services and support to the caregivers, both mother and father, is completely cut off. So I would say even more so than what are the research gaps, it's really around how do we take the evidence that we know, how do we take the programming that we know is effective and work and bring it to scale and actually start investing in communities, because that's what it is. When you invest in caregivers and young children, you're investing in the life and the success of a community. And for some reason, that is just still not done to this day, even though we have hundreds and hundreds of pieces of evidence that show to the contrary that we need to be investing.
Yeah, thank you, Ashley. Any of the other panelists would like to jump in quickly?
Yeah, well, echo everything that Ashley mentioned, and I think maybe just two additional points. I think one is we need to think about the processes and do research on the process. So how do we create these capacities? How do we train front-end workers, professionals, and how do we take it to scale? There's evidence that when we take programs to scale in general, you lose a little bit of impact. And so I think understanding what it takes to support the communities to be able to deliver the programs by themselves, what it takes to maintain quality and fidelity to programs at scale, it's super important. But I think, as Ashley mentioned, we have a lot of evidence of why this is important. I think we need to keep championing on why caregiver mental health is important, why you need these kind of more holistic and comprehensive programs. And I think this webinar is part of this efforts to put the message on the table and get it up and spread it up.
Yeah, thank you, Andres. Eduardo?
So, Patricia, you want to go first? Just to follow the same order on the presentation.
Sure. Very briefly, I think you mentioned all already. I think it's important to have this holistic view across different sectors and how can we integrate MHPSS components in everything we do in emergencies, and also always thinking on caregivers. We all know that investment for mental health across the world is very low, and also the political will to invest more and take action for child and adolescent mental health in general, including the mental health of caregivers, again, is very low. So we just need to keep advocating, sharing, our results, our evidence, our programs. And I think this type also of, spaces in which practitioners can share and discuss about what is working well can also be very useful. Over to you, Eduardo.
Yeah, no, thank you so much, Patricia. Yeah, I see two big gaps there. And actually, the first gap, I will say, is in evidence. We do have tons of evidence of the need of mental health and support. Though if you dig, there is not that much evidence in emergencies and the onsets of emergencies, the real deep emergencies. And that is an issue. And oftentimes, we are pushed back because they said, you have to show me why this should be a priority in the emergency, in the onset of emergency, with people talking about survival, and which is an issue. And that's why we created Hope for Our Children. We don't have that many programs in really emergencies where everything is just, falling to bits. And we do have a lot of evidence and programs, and we were able to adapt. And honestly, there are things, but still we have those gaps that need to be addressed. The second thing is, evidence is not enough. And that is an issue why, as Ashley mentioned very wisely, it's not prioritized. It just fell. It fell through the cracks. And I don't want to be too provocative there, but also these prioritizations usually in emergencies are also following a little bit of a paternalistic or a bit colonial models of who are our fellow human beings that are suffering in emergencies, right? And so they become statistics, they become less important, they become second-class citizens. And that is quite infuriating when you have a human rights approach on what we are not helping people in emergencies because we are good and generous. It's because we must, and because we are part of us. And because whatever happens to one person in humanity is affecting to whole humanity, right? That part of evidence is not enough. We have to have a much solidarious consciousness in the middle of the chaos and the or the groups fighting multi-sectoralism and the integration of more human solidarity, looking at the at inclusion and diversity and supporting gender issues. And this element of mental health support in emergencies is key to build a better society. And we have a lot of things to shed in the way we approach emergencies. We are oftentimes I said, we need to think children are not cattle that just needs to be fed. We are complex human beings with complex processes of development, with complex mental health issues that need to be addressed, and they need to be tackled, and they need to be done with solidarity, with love, and with attention, and with care. And that we need to have that and advocate very strongly. Thank you.
Thank you so much. Yeah, Eduardo, Patricia, Andres, Ashley, you all made brilliant insights and reflections. I really want to thank you as our expert panelist for sharing your knowledge with the community. Back to you, Priyanka.
Thank you, Nour, for the wonderful facilitation, and to all the speakers and panelists for their amazing insights. I think there's a lot of food for thought for all of us. So I think what we should do now is get into a small group discussion where we can reflect independently and with our peers on the various things that we discussed today. The two questions that we have for you are around: one, what aspects of the discussion resonated with you and which ones didn't? And second, did the conversation inspire any further ideas on how you can better support caregivers in your program? We can do this discussion in our groups for about 15 minutes, and then we'll come back and see if time permits, we can have one or two groups kind of share their discussion points with the larger group. Otherwise, we'll open it up for any broader questions that you have for the panelists. We see a couple of them are already on the chat, so we'll come back and pick those up. But even through sort of your peer group discussions, if something comes up that you'd like to ask to the larger panel, we'll use some time after that for this. So we'll divide you now into breakout groups. We'll also move the panelists into each of the groups if you can be there for a bit. There's also a document that was shared with you on email earlier today as a note-taking template. Since we won't be able to hear from all of you, if you can just leave your discussion points within the document, that'd be really helpful for us to just understand more about your thinking and where we can come in and support better. So please do use that for documenting your discussion in your smaller groups. Tejaswini, can I ask for your help in just opening up the rooms? We'll come back in 15 minutes. Hi, everyone. Welcome back. Hope you had great conversations in your smaller groups. We will not have the time to hear from every group, but I hope you were able to add some of your points to the discussion, to the note-taking template. If you weren't able to, if you can just take some time by the end of the session to add your thoughts, that'd be super helpful. But I really just wanted to open up for a couple of minutes for any questions that you may have for the panelists based off anything that you heard before or anything that came up in your small group discussions. So I just wanted to open the floor. So if anyone has any questions, you can leave it on chat, but please feel free to come off mute and ask the question directly as well. Would love to hear from some of you. Yes, Judith. I also see you have a question on the chat. So yeah, you can ask both the questions.
Thank you, Priyanka. Just a follow-up to that it seems the question has not been answered. Please, if I can have an answer from Dr. Moya for the question. Thank you.
Yes, Judy, thank you so much. I was typing and then we went into the breakout rooms. I think what you're mentioning is very important. I think both the mental health stigma and also a lack of awareness of how conflict adversities affect us create a barrier for people to take a step forward and ask for support.
to be willing to participate. And so what we've learned in these 12 years is that the community-based model is very conducive towards breaking this ice and breaking the stigma. And the community facilitators who have a shared experience, who have gone through these same challenges, come in and share their experience, share why they participated in the first time, what this has done for them. I think this allows the participants to connect in a better way and to identify that that this again is normal, right? And so what we've seen is that, and I think in statistics, out of every 100 people that come to our community engagement meetings, around 85% sign up. So I think this is pretty high, and it speaks to the way in which the community model helps breaking the stigma, helps start creating awareness, and to identify that again, these are normal reactions to very abnormal circumstances. And so we had a lot of difficulties at the beginning when it was me or a trained psychologist, usually like a white person coming to Afro-Colombian communities, indigenous communities, because they felt this is like totally distant from my own experience. The community model helps solving this.
Thank you much, Doc.
Any other questions, thoughts, comments, reflections? We'll also open up a poll side by side. This is just feedback for us and the session. So as you're sort of thinking through your questions and comments for the panelists, please do take the survey side by side as well. Thank you. I don't see any questions, but would anyone then like to very briefly summarize what you discussed in your small group discussion, and if anything interesting sort of came up from there? I see some of your reflections on the document, but if anyone would like to share it with the larger group.
Yeah.
Yes,
Shukran.
please.
Okay, thanks a lot for the opportunity. I'm Emmanuel Shukuru, speaking from Kakuma refugee camp. From the discussion in our room, we were 4 at the beginning, but one of us left due to the issue, due to internet instability, and then we remained 3. So we were more discussing on the concept of social and emotional learning, and how could we really promote this within not only at a home setup, but also at a school setup. We came to realize that in as much as positive parenting is concerning much the caregivers, thus looking at the home setup, we have parents who are supposed to do all their best to ensure that these children are being brought up in a more positive way, by them understanding the different strategies on how they can necessarily manage these children's emotions so as to enable them grow in a more positive way. We've also realized that coming to a school setup, we also have these teachers whom most of them have got less information on matters to do with social and emotional learning, whereby they are supposed to be informed on how to deal with the different emotions that could be affecting the children, because in a class you could find that you have children and each of these children might be affected differently. So now as a teacher or as a caregiver within a school setup, it's better to have these skills of understanding these children's feelings, these children's emotions, and being ready to guide them on how to manage them for a better learning, because it could reach to a moment when a teacher in a class might be teaching, but due to the fact that some of the children are affected back from their homes, when they reach to the classes, they might not be concentrating. And this requires a huge work for the caregiver within the class to understand how to handle or how to manage each child's emotions, so as to ensure that there is an inclusive learning that benefits all the children, rather than finding perhaps the teacher is teaching, but very few children are benefiting from the session, and knowingly perhaps that teacher is not even informed that those children are being affected differently. So that's what we were just discussing on. And it really stood out for us to find that both caregivers from the home setup, those are directly parents, so children's parents, and then coming to a school setup, we have their teachers who are all supposed to be trained on matters to do with the social and emotional learning, so as to enable a better holistic growth of these children and their well-being. Thanks and welcome.
Okay, I'm also from group 5. I don't know if I can go ahead to add to what Emmanuel has said. We actually talked about educators doubling as caregivers, not just responsible for the physical needs of children, but also for the emotional needs of these children, because every child is unique and different. And to be able to maximize the attention, we have to understand the underlying effects backing up the character or the behavior of every child. So it means that as caregivers, we need to be open-minded and educated enough to understand where each child is coming from, in terms of they could be coming from a domestic violent home, or a home that they are being physically abused, and then the child is not being able to express themselves fully in an educational setting. So as a caregiver, we're actually tasked with the responsibility of getting to know each child personally, understanding where they are coming from, understanding their the underlying effect that could be responsible for some behavioral changes or for some attitude you might be experiencing in the educational setup, and then go ahead to ensure that these children, we go ahead to, if we could manage a problem, if we could actually manage these concerns, not problems now, right now, concerns, if we could go ahead and manage them, that would be a better situation. And also at the end of the day, at the end goal should be being able to maximize their potential. Thank you.
Great. I don't see any other hands, and we're kind of coming to the end of our webinar. I wanted to thank you all for your engagement, your insights. It's been really brilliant. I really enjoyed it. I hope you all did. And we learned together what MHPSS mean, why it's important for both caregivers and child development. We learned the importance of having community-led programs, and the huge amount of evidence on the positive effects of having MHPSS services for caregivers. And we learned about the different types of programming and the minimum package of MHPSS for caregivers with young children in crisis and war.
Thank you. Now, can I say, yes, this is so great and so inspiring, guys. I mean, of course, you know, when I am with Ashley or with Carlos, I just, you know, feel like not only overwhelmed, I love listening to you guys. And also, I loved also in the room how there is this understanding of the importance of this, and this is so inspiring to hear to all of you. And a lot of people are doing little things, or they think they are little things in a corner of the world in Kakuma camp, or in Cameroon, or in Nigeria, which I heard. And those are not little things; they are huge things that have massive repercussion for the lives of those people. So thank you for the work you are doing. We hope that we can help you with our tools and our case studies and our experiences and our research. But the work that people are doing in the field in a one-to-one is massive, and helping one person can be a daunting task and a very, very difficult one. So a big hug of solidarity, of encouragement, and of deep thank you to all of you. And thanks, Nour, for your great leadership there. Yes, putting all of us, herding cats. So thank you.
No worries at all. Thank you all, for your insights and knowledge and sharing knowledge. And we did have a discussion in the breakout groups about all of the different case studies, the evidence, the programs that are being done in different countries. And we actually talked about how would that apply in Syria or Nigeria. And I think there's a lot of power in community approaches about breaking the stigma, but also there's a lot of, unfortunately, fears from people, specifically when we're talking about cultures that believe that if you have mental health, you're possessed, or it's because of black magic or things like that. And we were talking about how can we balance having community approaches to break the stigma, but also having the one-to-one private kind of support. We know it's more expensive, so we need to invest more in mental health, but it is, while we are raising awareness of the community, specifically, I'm talking specifically on collective community, when people are not able to speak in front of others because they will gossip, and that could even make them way more, their mental health way more deteriorated, right? So I think this was we need both and approaches, community approaches and the one-to-one support. We need to understand that mental health and physical health are interlinked. We shouldn't prioritize either or, but it should be both and we need to, we know now that the MHPSS are not expensive. They are not a luxury. They're actually essential for caregivers and for breaking the intergenerational trauma and poverty. And we know that multi-sectoral coordination is possible. Just seeing from the programs of nutrition, ECD, mental health that UNICEF has shared with us is really, really not that hard, and it's possible. So let's keep advocating for better coordination. Let's keep advocating for more funding for mental health. Let's keep advocating for more evidence in emergencies for MHPSS. And all of us are advocates, as Eduardo says, and all of us are, even in the smallest parts, are still doing change. Back to you, Priyanka. Thank you so much for organizing this brilliant series with GSF colleagues. And we're very, very happy to be here. Thank you all so much.
Oh, thank you to all our speakers and to all our attendees for their time and engagement. This also brings us to the end of our time. We'll be sharing all the documents, resources shared, and the recording of the session as takeaway emails shortly after. But if you'd like to connect with any panelists, please do exchange messages on Zoom chat. Lastly, the next session is next Wednesday at the same time with Amna, where we're going to look at trauma-informed practices and how to build safe learning spaces and healing spaces for caregivers. So we'd love to see you for that session as well. Thank you so much, everyone, for your time, and have a good rest of the day and evening, depending on where you are. Thank you again. Thanks, everyone.
Thank you so much.